So our cleanup speaker for this panel and for the conference needs no introduction, but I can't help myself, but I'll try to keep it brief. Sheryl Skolnick is Managing Director and since September of 2011 has been co-head of research for healthcare services at CRT Capital Group LLC. She has more than 24 years on Wall Street and has been named Wall Street Journal's Best on the Street in Healthcare 5 times. She has served as an economist for both the U.S. Department of Labor and the Antitrust Division of the U.S. Department of Justice. She is regularly a featured speaker, a frequent guest on numerous television business shows, and is widely quoted as an expert on healthcare issues. We are very fortunate to have her here. She is renowned in her industry for her differentiated research, her unique perspective, and finding what others have missed. So I think we'll get a little bit of insight on that over the next 20 minutes. Thank you, Sheryl.
Okay, good afternoon, everyone. Almost, good morning. And first, let me, as others have done, but since I'm the last speaker, could we have a rousing round of applause for Paul, Margaret, and our sponsors for this year's conference. Widely regarded as the best of these sorts of conferences for a lot of reasons, and I'm honored as always to be asked back, so thank you very much. So this year we actually have something to talk about. Last year I felt was kind of a little flat. There wasn't really anything we could say yet, because frankly we didn't know anything yet. So many things had not yet been decided last year in this time about what reform was actually going to look like, whether or not exchanges would work, et cetera. And so this year, there's certainly a lot more to discuss. There's a lot more to debate about. Is John right or am I? On premiums and how they're established. We can have that debate in the Q&A later. And also, of course, the political environment, which, you know, is a bit of a mixed blessing. Sometimes I'm really pleased that Congress is in gridlock because I'm really afraid when they actually do things, they're not things I want them to do. And we're better off with them being inactive. And then sometimes I'm really afraid by what I hear from folks like Norm Ornstein with their very insightful comments about the structure and issues and risks in our political structure today. So moving on, I'm going to today talk about the impact of the implementation of the ACA as requested and other assorted fantastical events. So, as I try to do every year, hold myself accountable for what we said last year and whether or not we were right. This is a forecast conference. I'm supposed to be an analyst who makes forecasts all the time and live and die by them, so you can hold me accountable for that. So let's see how we did. If it's in black, it's what I said last year. If it's in red, it's my own self-assessment tool. I won't do it online for healthcare, but I will do it in real time for you with respect to my picks and forecasts. Reforms unknowns were many, okay, but reform is good for hospitals, so buy the stocks. Well, you know what? It sort of worked, and I have a slide that's coming up next to show you whether or not it did actually work in terms of if you bought hospitals, did you do well throughout 2013 moving into 2014. But the truth of the matter is that 2014 is a big year for hospitals in the public marketplace. They're all supposed to be telling us actually now, real time, either in the last couple of weeks or Tenet Healthcare being the last major hospital to report, will report next week, what they think their contribution to 2014 earnings will be from reform. And it had better damn well be positive given where their stock prices are. So, you know, there's a lot hanging on this. Reform may or may not be good for hospitals. Yeah, actually that was right. We were right to say that. For example, the range so far is that HCA has said at most it thinks this year 7 to 9% of their total uninsured admissions will be covered this year by reform. LifePoint Hospitals, a smaller rural provider with a lot of exposure to Medicaid opt-in states, says that up to almost 20% of its uninsured volumes will in fact become insured this year. So there's some big variation, but it's still not the majority. And there was this sort of view, if not fairy tale myth-like scenario that many Wall Streeters had, which was that everybody was going to get covered. It's universal coverage, after all. I mean, therefore, everyone will get covered. All bad debt will go away, and life will be wonderful. And you're laughing because, if anything, we might have actually made it worse. So we'll find out. We're also looking at whether or not things are still unknown. So, for example, the timing. Will exchanges actually be ready? Well, that was a good call on my part. Yay. Exchanges, except I will say, I actually thought that the federal exchange could be modeled off of things like Medicare Advantage, that they actually might have had a head start. California was unique because they got started right away, and I said, what are they working so hard for? Congratulations, you were right, I was wrong. There were lots more things. It was a whole lot more complex, certainly, than anyone on Wall Street had an understanding of. But, as we learned more, this year, last year and this time, we actually began to understand the nature of the complexities, how difficult this was going to be, and even maybe the federal exchange might not be okay. So it turns out it wasn't. Now, so we had the circus of the hearings on Capitol Hill, which if anybody is old enough to have seen the Salem witch trials, I imagine they would have looked a lot like that. But what was very, very clear was that whoever was running the federal exchange, it would have been nice if they would have raised their hand. Obviously, no one did. They needed someone to come in and do that. And the unexpected hero of the day was none other than QSSI, which is owned by Optum, which in fact is owned by United Health Group. And we'll get to that later. Exchange provider network structures. So we have narrowed networks. Now, I have to address a question sort of to the group. So in this day and age, why on earth does somebody still give a member a choice between a $400 provider for an MRI and a $4,000 one? Why is there a choice? Okay, this is a narrowed network environment. The criteria needs to be, if the quality of the $400 MRI is good enough, get rid of the $4,000. All right, that needs to be a big flashing neon sign to high-cost providers. You will be eliminated from being able to provide to these members. So rationing via performance is what narrowed networks are about, and also rationing based on your willingness to accept discounts, which is a lot more dangerous for both the plans and the providers, never mind the patients. But in any event, it's here. It's going to stay at least for another little while. And exchange provider pricing was really, really interesting. Even though we have narrowed networks, by and large, the providers won that battle. They were able to say to the plans, nuh-uh, we're not taking Medicaid minus. This is a commercial-based plan. You don't have a single person yet enrolled. You can't guarantee me any volume, none at all. What do you mean give you a big discount? Not going to happen. So what we've seen among the publicly traded companies is, by and large, it was a very, very, very small discount off of commercial managed care. And one of the things we did see, for example, is that HCA, very, very large, some of the highest and best pricing in the market, some of the biggest price increases in the market because they're locally dominant where they exist. Basically, and I can tell you that the price differential could be 20% on a commercial managed care revenue per adjusted admission. It's very, very significant for them. The health plans would love to see them have, shall we say, less rich pricing. But what they decided to do was to not participate in narrowed networks in many of their markets and then just simply go out of network for pricing if the uninsured show up. Rather than risk discounting, giving something up in exchange for no volume, and breaking their commercial managed care pricing structure. Okay, so that was a very, very interesting and quite frankly unexpected outcome. Medicaid opt-in, big warning light. Arizona, private option, maybe not going to be renewed. There's two guys in the House who are holdouts, apparently. Maybe they can get it to be revoted on if they figure out what those two want. But, if it fails in Arizona, maybe it fails in Pennsylvania and some of the other states, Missouri and others, that are looking to perhaps as an option. You can forget about Texas and Florida at this point in time, in my opinion. I still wouldn't want to be a poor person of color in Texas, that's all. And it's a very, very sad thing until they learn how to vote. And then quality mandates and revenue risk. I'm going to take these two things together. I mean, certainly we said these two things were unknown with unknown outcomes. Someone said earlier, and I applaud it, just because you can take risk as a hospital or a provider doesn't mean you should. Put some exclamation points after that, please. That is a very, very real lesson that should have been learned. Again, someone else said yesterday, it looks like 1994. Yeah, it's kind of scary. It looks like 1994. Please remember what happened to all you hospitals out there when you took global capitated rates in California in 1994, 5 and 6. Okay, this was not pretty. And then in terms of the quality mandates, we've actually seen a lot more talk. We are actually seeing a lot more action. We're seeing very significant participation. And then moral hazards, the readmit cuts were absolutely real. Medicare ACOs, the Pioneer ACO program is maybe a little less than successful, shall we say, but private ACOs are on a tear. And the ability to take risk and be responsible for the behavior of those whom you cannot control, as well as downstream providers, so in the patient's home, is a very real risk that scares the daylights out of me, that tells me that I want to watch these hospitals who participate in that very, very carefully. And quite frankly, the physician groups too, because doctors, I'm sorry to tell you, you can't control everything either. And the other thing I want to mention here while I'm here is, we look at what the physician groups are doing, and they're really dramatically reducing hospital length of stay, okay? And one of the things they're doing, and one of the ways they're doing that, is they're making these specific populations much healthier. If you keep people healthy, if the goal of the doctor is to keep their patients healthy, they're not going to come to the doctors either. So what's happening to hospitals today may be the model for what's happening to doctors in the future. Lots of capacity, no heads in the beds, declines in revenue and pressures on margin and profitability. You might want to watch out for that. So how did we do? So I have to give you at least one stock price chart because I'm a Wall Street analyst and this is what we do for a living. Can we see the pointer yet? All right. Is it my nails or is it, there we go, yes it is. Okay, so last year, this is the last year chart that I put up, okay, exactly copied from last year's presentation. This is this year's. And so what we said was, the really great theme coming out of Wall Street for 2013 was reform is good for hospitals, buy hospitals. And in fact, the green line is United Health Group as a proxy for the health plans, okay? And the white line is HCA as a proxy for the hospitals. And let's see, so 2013, early part of the year, this is where we were. And it looked like, boy, that was absolutely going to be the right call. These hospitals were on a tear, except for one thing that the market forgot. Fundamentals always matter. Volumes were horrendous. So what ended up happening was this, which actually went from February, where we started to have problems in late February, into March, and then April, when they finally started reporting the first quarter. What we saw here was very unexpected negative surprises, okay? So first it's negative, second it's unexpected, third it's a surprise, it's a triple whammy, the stock goes down. And then what ended up happening in here was nobody could figure out where the patients went. I mean, we really couldn't figure out why demand was so catastrophically low and why companies were failing to meet earnings expectations. And to some extent, we still can't figure out why demand for inpatient care, well, we think we know, but the companies certainly were unprepared for it. And as a result of being unprepared for it, they did not staff accordingly, and their margins went south and they failed. In addition, there was something I'm going to discuss later, which was little bits of problem in behavioral change affecting HMA. And so that too weighed on what's going on here. The conversion from inpatient short stay admissions, 1 and 2 day stays in Medicare, to observation care if you're in the hospital business, you've got to be worried about this. It was shocking to me to find out from the hospital companies that they actually admitted that in some cases, for some of the companies, that short stay, 1 or 2 day stays, could be as much as 20 or 30% of their admissions. Now, if you're in a rural hospital with low acuity cases, that shouldn't be a surprise. But even some of the higher acuity providers have 20% of their admissions coming from short stays. With the 2 midnight rule and with pressure from managed care companies and really scrutinizing short stays as part of a coordinated effort to reduce overbilling in Medicare, which my tax dollars thank you, that is really what's happening here, is that managed care through, and Medicare, through changes in, and really activist kind of changes in their approach to managing claims expense, are really pushing down on the number of hospital days through conversion to lower cost outpatient kinds of cases. So, in fact, for the most part through 2013, the better plays were to be invested in managed care organizations. And then take out fever and consolidation speculation started, and the hospitals started to come back up, and that was in late summer. So let's move on. Okay, the impact on reform on hospitals. Now, Wall Street loves an optimistic story. We are fundamentally biased to be optimists. I don't know why I'm actually in the business, because I'm actually not an optimist. I'm more of a pessimist, but that's okay. Just ask my husband, poor suffering soul. Anyway, so the impact of reform on hospitals. We value hope excessively. It's so easy to say, oh my God, this is going to be so fabulous. Community health systems is going to be a $100 stock. It's at 40. It's going to be a $100 stock because this is going to be great. So this was the hope. White House is the proxy for hospitals. Thousands of people lined up to get in because they're all newly covered on the exchanges as of January 1, 2013, and they've all paid their bills and their claims are going to be submitted the next day. Okay? Standing room only at the hospital emergency room door. Of course, the hope and the reality are just a little bit different. Come on, guys. This is the reality. We have barely seen one patient show up as being newly insured in the ER at any of the publicly traded hospitals to date. The only evidence we actually have that reform is something more, other than a bust for the hospitals is that Community Health Systems said when they reported earlier this week that they are seeing a reduction in no-pay admissions that's higher in the opt-in states. That reduction is bigger in the opt-in states than it is in the opt-out states. The little issues with causality there, okay? It's not clear what the lines of causality are there. But, okay, we're pulling at straws. We're pulling at straws, and we're good for that. On average, we expect about a 2% increase in EBITDA, our major profitability metric, in 2014 as a result of reform. That's way short of the billions that we thought these guys were going to get in windfalls. Now, part of that is the delay. Part of that is the lack of membership coming in through the exchanges, but also that not every state is an opt-in state. And it's also the geographic location of the publicly traded hospitals that are mostly in states like Florida and Texas, and the southern tier of states that have not opted in. Unless you're a health plan playing the exchanges and needing to play the exchange like a WellPoint, for example, because you have to preserve your downside of the loss of the individual lives that you covered as the blue plan in the state. So yeah, it's no great surprise that the blues are the dominant guys on the exchanges because they're actually protecting their backsides. Unless you're that health plan, it's not much more than a bust for you if you're a health plan either. And then, of course, depending upon what happens with who you actually insure, winning lives on the exchanges may be a bust as well. So let's just quantify, because that's the other thing Wall Street analysts are supposed to do, is supposed to quantify what some of the substantial burden is on hospitals and fee-for-service providers and health plans in 2014. United Health Group gave us probably the best data and breakdown of this. It is going to cost them from MA cuts, and yes, we are aware the next round comes out tonight, So Medicare Advantage cuts, the industry fee and the tax, which is not deductible, which they may not be able to get back from state Medicaid plans. It's a whole mess. The MLR regulation and rebates, it's very expensive actually to monitor that. It's basically county by county. So it's not just that you're now having the regulation of your margin. It's actually the calculation of it is non-trivial and not cheap. And then, are you really serious? You're going to eliminate the 3 Rs? Are you really trying? Do people really not understand just how much risk there is in participating in these exchange plans? Is there really a view out there that this is just simply a money-making way, a way to transfer tax dollars to health plans? Because if that's the case, the health plan industry has done a really horrendous job of PR and should fire who's ever advocating for them. All right, this is a risk-sharing arrangement. This is not a money-making arrangement. This is protecting you from going belly up on your exchange product. So let's just be perfectly clear about that. All right, and then sequestration, of course, hurt. So it's going to cost them $1.5 billion in 2014 by their projection in earnings. $1.50 a share, $1.5 billion, one company is lost. So for all of those to take you back to the environment in which health reform was passed, and we just wanted to stick it to the health plans, congratulations, you did it, okay? This is a big cost. They can no longer be a price setter in their marketplace because rates are, right, remember in the old days, just to take you back, if WellPoint's former CEO didn't like something, she'd say, oh, well, we'll just, charge the member more. Okay, we'll just pass it along in premium price. That game is over, costs are higher, margins are compressed. The game has really changed, and the cost for one plan alone, $1.5 billion. For hospitals, reform has been a net negative. It was cuts before coverage, and anyone who's living through managing that right now understands that while urban hospitals have seen an increase in Medicare pricing generally, rural hospitals have not. So what's the difference? Before sequestration, HCA, for example, got a 2.3% price increase from Medicare last year. LifePoint got a 1.1% decrease before sequestration. Sequestration is 2%. So you can see the difference between haves and have-nots building. The real problem here is that unless and until we get substantial coverage of the uninsured and eliminate the bad debt by replacing it with positive cash flow, you can't just cut and make them go away. You got to replace them with positive cash flowing volumes. This is a bad trade for the hospitals. And of course, all of the population health management and all the narrowed networks are working very hard to make that not happen, to make hospital bed days go down, to make sure the hospitals don't turn a no-pay head into a some-pay head and a positive cash flow event. The one thing I do want to mention here is actually two things here. To the extent that any of our Washington friends are still here, I'm still advocating for a home health copay, folks. The utilization there is tremendous. I gather that you need something to pay for the SGR. I'll volunteer. Home health copay is one idea whose time has come. Not only because, full disclosure, I have a cell rating on Amedisys, which is one of the larger providers of home health care in the United States, but also because as a taxpayer, I want the right incentives for excess utilization to be eliminated. So let's move on to other fantastical things in 2013, just to entertain you, okay? Will you please let me say I told you so? In December of 2012, two things happened. One, 60 Minutes came knocking, as I told you last year, on HMA's door with a program called the Cost of Admission that alleged that they were pressuring physicians to hit admission benchmarks. And that, the allegation, of course, was that they were doing so in an illegal way. We actually, that evening, next morning, put out an extensive statistical analysis of, the PhD had to be good for something, of the patterns at a local level that we saw in differences between HMA and its local peers, as well as at a statewide level. And what we found was the unfortunately predictable outcome that not only did they look different than their peers from the data, but also behaviors changed after the new CEO arrived in 2008. So we played a major role in bringing that information to the marketplace. It landed with a thud because Glenview Capital and others had very significant positive investment thesis about buying hospitals, one of which was HMA, and Glenview became the largest shareholder. Somewhere in and around March, April, May, they saw the light, figured it out. Maybe they finally read my research, and decided to go active because management of HMA had a horrendous first quarter, was shaping up for horrendous second quarter, and they sought to replace the board of directors. What ended up happening after that was they were successful, but what it did do was it put a lot of pressure on the organization, which was already under extreme strain and was having, when I talk about horrendous volumes, down 10%. I don't know how you survive that. And all of a sudden, late spring, Gary Newsom, the CEO, resigns suddenly, retires. He's announcing that he's been asked to become the president by the church, the president of the Mormon mission in Uruguay, all of which led to that, consolidation. Community and HMA merged. HMA's stock price soared into the high teens. It was a take under, which is very unusual. It wasn't the only consolidation in the industry last year. Tenet and Vanguard merged, so they fell in love and married too, which is a kind of a scary thought if you know the guys on the management team, but that's okay. This was even scarier, as there was absolutely no love lost between the chairman and CEOs, the chairman of the board of HMA, Bill Schoen, and Wayne Smith, the chairman and CEO of Community Health Systems, prior to these negotiations. And then they got a new board and CEO, came in and said, okay, yeah, we bless this merger. And then that happened. The end of December, all of a sudden, the DOJ unseals 8, count them, 8 qui tam whistleblower lawsuits alleging fraud of a very specific type across almost all of the hospitals, orchestrated allegedly at the Naples headquarters, naming Gary Newsom, the CEO, as defendant. This is highly unusual. So can I please say I told you so? Now, how does this fit in with the implementation of the ACA? For those of you out there who are participants in the healthcare system, whether you be a provider or payer, the ACA empowers employees and others to become whistleblowers. It is one of the single greatest factors in the increase in anti-fraud activity at the DOJ and within the task force that we have seen, and it is making a major dent and difference in the behaviors of and lives of the publicly traded companies I follow. Now, there were 7 other cases just like this. What are they alleging? That the allegations are, and pretty consistent, that they set arbitrary benchmarks based on profitability and not based on patient need and assessment by physicians, and bribed, threatened, fired, did other things allegedly to physicians who did not comply, or to favor those who did, including entering into more than 20 whole hospital joint ventures with said physicians and allowing them to contribute worthless assets as their part in the joint venture, allegedly, in order to become part owners of the hospital and grasp their volumes. This could have very significant ramifications for the new owner community, despite their efforts to ring fence it, and of course for Gary Newsom himself. So, in case you were wondering, Mr. Newsom, as I will remind you, had gone to Uruguay just before all of this stuff gets unsealed. That is the extradition treaty with Uruguay, which is why it is in your presentations. It was signed in 1973. It was finally ratified under President Reagan in the early 1980s. However, the update here is we won't be needing this because Mr. Newsom apparently was recalled by the Church of the Latter-day Saints. We don't know why, but he was, a few weeks ago, recalled to the United States and replaced as president of the Mormon mission in Uruguay. On a cheerier note, so healthcare.gov is a disaster. Congress has a field day with the hearings. Clearly, something must be done. But wait, along comes the white knight. And I don't know if you can read it, but that says QSSI, right? That says Optum. And they came riding in, congratulations, they come riding in on as close as I can get to a white, knight in shining armor on a white horse. My husband rides a motorcycle, so this is a tribute to him, to save the day. Now, this is really fascinating, okay? I'm going to come back to something I've talked to you about before. Optum as the agent of Optum is the agent of transformation. Optum as the part of a health plan company that's not even participating to any great extent on the individual exchange. 4 of them, 3 of them are state-based. The only one that's not is Alabama, and that's an interesting story to begin with. But if you look at what they're doing, they say, we tell everyone our reason for being is to fix what's broken in the healthcare system. If they didn't take on the opportunity to become the general contractor to ensure that the end-to-end fixes that were needed, that needed to be done in a month's time to the healthcare.gov exchange, if they failed to do that, how could they go out to any other customer or to Wall Street or even internally and argue that they are all about transformation, fixing things that are broken, and making healthcare work? They had to take this on, and given that all eyes are on it, they had to succeed. They did. They've since been hired by Minnesota and Maryland to help them in their problems. And it's been kudos to them. But it is the best example I can see of fundamentally, absolutely, and permanently fixing a broken healthcare payment and delivery system. So the questions for next year, will hospitals ever see these volumes, or will it be a very lonely time at the White House? Will exchange enrollments hit targets? Will they be newly or already insured? And by the way, that is a very big issue for Wall Street. We need the frequent flyers who end up in the ER to get covered and to, still be frequent flyers for all the numbers to work. Will enrollees figure out how to pay their premiums and copays? Someplace better start taking those checks. Will we have enough primary care docs? Not enough of the hospitals are focused on the primary care networks. Kudos for being focused on the primary care networks. You need to be in that business, not only for population health, but because that's where all the health care is going to happen under reform if it's done right. Will hospitals learn how to take risk? God, I hope so, because more and more is being heaped on them. And will private exchanges change the face of managed care? Yeah, more employers are going to end up taking more risk, all right? So if employers take risk and hospitals take risks, what's a managed care company to do? Why do we even have them? It's a question they're going to have to answer. And then finally, something we didn't talk about at this conference, I really wish we had, was how do we pay for the SGR? We need it. Needs to be done. Let's find a way to pay for it. And with that, I will say thank you yet again for another really tremendous conference, and congratulations to Margaret and Paul.